Alyssa Meller, Director of Operations, and Joe Voda, Chief Information Officer. Alyssa joined the center in December 2013 and brings over 10 years of managed care, Medicaid, and Medicare experience. This experience includes care coordination, program development, quality improvement, and collaboration with local and state partners. In addition to overseeing the operations at the center, Alyssa works with the networks and rural communities to understand the critical components of care coordination and how it is an essential part of the new value-based payment models. Deborah joined the center in April of 2015 and brings over 30 years of adult education experience. As a program specialist, she provides education, coaching, and technical assistance to rural health networks on topics such as strategic planning, evaluation, collaboration and community engagement, partnerships, and leadership. She utilizes her extensive background in training, facilitation, and presentation skills to assist rural health network leaders to accomplish their goals. Joe has been at the center since 2012. He is also a health information technology consultant for Rural Health Innovations. Joe has worked in information technology since 1990 and with HIT since 1993. His work with the Minnesota and North Dakota Regional Extension Center for HIT includes meaningful use assessments, privacy and security risk assessments, readiness assessments, workflow analysis and redesign, project management, quality reporting, and tool design. Along with staff at the center, Joe provides technical assistance to rural health network grantees nationwide, as well as providing HIT assistance to TASK. Joe has been an IT manager, director of IT, and CIO at several hospitals, clinics, and other healthcare organizations. He has assisted healthcare IT vendors with business planning and product improvement. Joe's expertise is in IT leadership, strategy, service delivery, and the process of innovation. He has led several selections and implementations of various HIT systems. Now I'll turn it over to Alyssa, Deb, and Joe.
Great, thank you, Kim. This is Alyssa, and I'd like to second Kim's welcome for joining us today. It is part 2 of our care coordination and its role in transforming local healthcare webinar series, and I hope that most of you were able to join us yesterday. But if not, just a brief summary of who the center is. The center is a national nonprofit organization located in Duluth, Minnesota, and we really focus our efforts and our mission around sustaining and improving healthcare in rural communities. And we focus that assistance in these 5 core areas that you see on your screen today. And I wanted to take just a moment to review the objectives of yesterday's session and today's session to jump off and be our platform for moving forward today. So we spent some time yesterday understanding 2 of the 4 fundamentals of care coordination, and today we'll spend the remaining amount, our portion of our time today talking about the 2 other components. Today, we also briefly hinted at some healthcare information technology and the needs to keep that in mind as you're developing your care coordination model. But today, Joe will be getting more into that as well. We're also going to today talk about and address some of the concerns and questions that we've often received and helped with in regards to privacy and security when working with multiple entities. And then we're going to look at with Deb. Deb is going to provide us with some best practices and lead us through some discussion in your role as a hospital, clinic, or facility in engaging those local providers and community organizations in your care coordination model. So today, like I briefly mentioned on the previous slide, we're going to really dive into and understand the 2 components of care plan and the care team, engaging your community, privacy and security issues and commonly asked questions and myths that we hear, and then have a discussion around health information technology and how it can support your care coordination model. So the 4 components that we have identified through interviews with many different care coordination models, whether they be hospital-led, clinic-led through patient-centered medical home, or through networks, which is a partnership, a joining of different organizations, is we were able to pull through that experience in those interviews that each of the models have these 4 components that you see in front of you on your screen: target population, assessment, care plan, and care team. Target population, just to remind everyone, is when I say that out loud and when you hear that, it's really improving the care, health, and reducing costs for a specific group of people. Assessment is a tool or a survey used by the care coordinator, care team, and or the person, depending on the model and the goals that you're setting forth for your model, to assess a person's level of need for services and coordination. I'm just going to flip the slide here to bring the definitions of the care plan and care team forward. And care plan is an individual plan of care that is developed with the person, caregiver, and providers to identify the person's needs. Care team is a team of interdisciplinary providers identified with the person and or caregiver that represents the clinical, behavioral health, social services, long-term care, community resources needed to help meet the goals and outcomes of the person. And each of these 4 components, I'm not saying them in any particular order of importance, but that they are identified components that need to be thought through and addressed when you're establishing your care coordination model and bringing in those community partners, those local providers as well. We have a few words underlined on this slide with, and I'm looking at the care plan definition. The with is very important because as you're developing a plan of care with the person, that will help ensure engagement and outlining goals and things that the person will hopefully participate in and reach towards as well. And is because it's important to bring those key providers to the table too when you're developing that care plan, so everyone understands the goals and outcomes that are being addressed with that person. So some of the questions as you're thinking about the process or the fields or the components of your care plan and what does that mean for us, these first 2 questions are important to really dive in and to think about. What is the function or the purpose of the care plan that you're wanting to create with the person and your provider team? What is the approach used in development? And I alluded to that a little bit, and I think it's indicative of how the definition is described. But the purpose and the function of the care plan, that final document, it needs to be able to provide guidance, instructions, interventions in achieving that goal of the outcome. And why it's so important to create that care plan with the provider is that it's in words that person understands, that person can go back to and say, yeah, I know what I'm trying to reach here, because it's in words that they understand. So as you're working through with the person and developing their plan of care, it's important to have them state back or reflect back the information that you're talking about and capturing that information on the care plan, because those are the words that they are using and understanding as well. The approach that is used in development, and it really needs to be with the person and the provider team. Again, to meet the goals and the function and the purpose of the care plan. If you're doing it on your own and then presenting it to the person, like, here you go, here's what you need to do to get that proper diabetes management or behavioral health needs met or address those issues, it's not going to be as effective unless you build that with the person and the providers and the key people that person wants around the table. The other area that is really important to think about is, what are you going to include on your care plan and how do you gather it? And some of the things, other than specifically clinical needs of a person, such as their medication, their treatment care needs, but advanced directives, depending on the model that you're focusing around, it may be very important in any case, in any model, to have advanced directives. Do they have one on file? Do they not? Preventive care needs is another important aspect to include, because as we're reacting to acute condition and have them more stable, and that's the purpose of care coordination, is to reduce, to address acute in flare-ups or intense situations, preventive care needs to help them stay on top of their annual exams, their preventive screenings and things like that. Also, disability status is important too, if there's any special needs needed as well. Other important components for a care plan are their social needs. And as we learned yesterday, a big reason why there are barriers to health status or predictors of health status are those social determinants of health, those socioeconomic statuses. And so when you think about the social needs, it's things like, and this isn't an all-inclusive list, the transportation needs. So maybe through the course of talking and getting to know the person, you don't have reliable transportation. So understanding, that their social needs are. Maybe they've talked about food assistance, that they are visiting a food bank or a food thing, or they're in a shelter. So really understanding what are some of those social determinants that may affect them from having their health at the forefront of them as well. Other social needs that are important too are adult and child protection. Maybe you're working with a person that is under protection at the county or at a certain level, however your state works at. It's important to know that they're under protection so you know who to talk to and who to work with for medical type decisions and or other decisions. And if they have a guardian, not only, I'm not speaking to just the adolescents or the under 18, but those folks that may have a disability or a need that is where they've had a corporate guardian or a personal guardian assigned to them. Demographics of a person is another important component of a care plan. Their living arrangement. Where do they live? Are they in a nursing home, foster care, group home? That is, and it helps you understand and maybe some of the challenges or benefits or assistance they have available to them. Language and or other cultural specific needs. Is an interpreter needed? And that's maybe why they haven't been accessing routine medical care on a regular basis, is because language is a barrier. Another area that I like to talk about is having the payer indicated on the care plan too, because sometimes, and as you guys know, my background is Medicaid, there are different coverages available with Medicaid insurance depending on the state you're involved in or you're living in and operating in as well too. But sometimes that's not an indicator of how you're going to treat the person, but what's available to help assist the person as well too. In the other area, because that is important to include and that I haven't mentioned yet, and because the goal and the purpose of the care plan is to provide that instruction, is to really include those instructions, the guidance, the goals in a language, in the way, I call it layman's terms, that the person understands, and that they can use this resource as to help them of what to do when they have this question or what the goal that they're trying to meet as well. And then these last two areas in the care plan, really, once it's developed, once it's implemented, how are you going to communicate to the team, to the person, and the family if necessary? So how are you going to provide the final document? Is it going to be electronic? Is it going to be paper copy, hard copy? How are changes going to be identified? Who's going to be on point for those changes? And then again, how are you going to communicate those needs and those changes out to the care team and or the person and family? And then keeping in mind as you're thinking through these questions and the goals of the care plan, how can technology help you with this to make it more simple and more efficient of a process? This page is an example. We had a workshop in August and with hospitals and networks, and we used a tool or a table to help guide them through this question. So here's an example for you to see how this network answered, their areas for their care plan. Their question or their, how they're using their care plan or developing it it's very family and specific to that family. So it's very individualized. It includes the strengths and resources that the family has currently available with them, and that we cannot force the parent to do something they do not want to, so try to focus on the small goals and grow from there. And they really took the approach of that it's a family-driven and it's going to be patient-centered. and that some of the interesting components they chose to call out here were the interventions that we spoke about, and then family strengths are incorporated into that too. So the strengths being, how are they going to support the child? And I should have mentioned that the example for this care plan, for this example, was their target population were adolescents and families who had a hard time accessing mental health services and healthcare services specifically. And they're going to choose to communicate it by through their care coordinator, and that they must sign off on that care plan. So once it's developed and it's written out, that they're looking for a sign off by the person, that's responsible for that child. And if they are under 12, they don't sign it, but it looks like that if the person is 12 and older, that to help engage them in their care, they're having them sign off on it as well. And they're using their care plan development, or their template, is an Excel spreadsheet. So simple, you may think at the top of your head, but it's a tool that they were able to use and create to support their care plan to get it going. The second area that I'd like to talk about, and the final area of the 4 important components, is the care team. And the care team, when you think about what does that mean, and how's the approach to developing who is on that team. And I'm just going to put all of the bullet points up here. Oops, excuse me, get a little quick happy there. When you look at the interdisciplinary approach and how to do that, it really needs to be a representative of the clinical needs and specialties of that patient. And it may be different for each person, even though you may have a very clearly specific target population outlined. And you have one person that you're working with and then another person, it still may be different for each person. Examples: primary care and specialty, behavioral health, long-term care if it's an elder population or disabled population that you're working with, and home health agencies. They're great resources available to help assist folks in transition back home to a least restrictive and more cost-effective environment as well too. The other area and why we're here today is the community partners, and including those a part of the care team as well. And I can't stress enough the importance of being inclusive of community partners. And when I'm referring to community partners, I'm thinking social services, public health, transportation. I already mentioned behavioral health, but another important partner that I'm seeing really develop that's being brought to the table are the schools, the teacher, if it's working with children from a behavioral health component, bringing the teacher involved into that, discussing the behaviors that they see and in the classroom, and or the school nurse as well, if it's more of a disease-specific program, asthma as well. Really bringing some of those community partners that's so involved in every, the patient, the person that we're all working with and trying to support and lead a well life. The care coordinator or the team leader, and the second bullet here is, we hear the term care coordinator, patient navigator, community health worker, team lead, discharge planner, and really each person has a different role, a different skill set, licensing requirement. And even though we know we need to have a team approach to the care team, it's important to provide a primary contact for the person so they can assist or they can answer those questions. And who that person is, whether it be an RN, whether it be a community health worker or so forth, those are just a couple of examples. It really is going to be dependent on the needs of your population and that end goal of who you're trying to reach. My experience a lot has been with the Medicaid population, and so it's not, we do need an RN on the team to help with the clinical disease management of that population. However, as we know, social determinants, and so a social worker, community health worker often is really that point person to help address some of those more social determinants of health prior to then getting in and working in on the disease model as well. And so another question is, who's part of the care team? And I've talked a little bit about this. However, a question came up yesterday, I think, is does everyone need to be part of the care team, at that face-to-face visit? And that's a question that you need to reflect and think about on your care team. You know, it definitely is important to have those core providers, the medical, specialty, and those behavioral health. Again, it's going to be dependent on the model and who you're working with and who needs to be at the table, but it also needs to be representative of who the person and or their caregiver wants at the table as well too. It's okay to list transportation providers, you know, on the care plan, but not at the table because that need is identified. So it's really going to be, what's the acute need? What are you addressing first? Who's around the table? And it will change as you progress through working with that person as well. And then the last two bullets, how will the care teams communicate with each other and the person? How will technology be used? And communication, this is tricky. It's not easy. It takes time to develop that communication process. But it's so important to identify that workflow between your core care team members, your more peripheral or identified but not involved at the table, and the person and their guardian. It needs to clearly be articulated on who does what, when, and that it's written down in some type of procedure, job description. Maybe it's in a memorandum of understanding or a charter, depending on how formal your network or your care coordination model is being. Because as you learn and bring forward those community partners, those community managers, you're going to see overlap, and that care manager term, that care coordinator term, is going to be used a lot at different organizations. You're going to if you bring the social worker, you're going to hear maybe a county case manager, a care manager. In the Medicaid world, you're going to hear care coordinator manager at the payer level. Patient-centered medical home, it has a care coordinator. And so that term is used widely and broadly, and so understanding those handoffs, those referral processes is important, and everyone knows their spot in that process. And then technology, how can you communicate between the two? How can you provide an update that someone was in the hospital or visited the emergency room, or that their care plan was updated? And Joe will be leading that discussion in a bit as well too. And then my last part today is again the bringing forward that example of children, adolescents, and families who have had a hard time accessing mental health services and healthcare services in general. And this is how they completed and answered and worked through those questions. And then they were so from an interdisciplinary care team, they indicated that they bring any service provider that is involved with that family services. Constant is the primary care physician, school, sometimes mental health provider, and if it's really a young child, early childhood intervention, and the care coordination. It's very specific. They tailor it around to that family. Because they are working within a Medicaid model, they had some requirements. They needed at least a bachelor's degree so that they can build Medicaid for those care coordination services. And so their particular model, they look for and require a degree in psychology or education because of the type of coaching, education, and work with the person. And then what provider or partners are part of the care team, it's dependent on the client, but if you go up to number 4, that's who they look at and they involve in the care. And I liked this example of how they're communicating with the person and their team, is that they have biweekly team meetings, and the staff is constantly on the phone with each other. That allows, them to touch base, what's working, what's not, what is evolved. And supervise individual one-on-one meetings every other week with the care coordinators, and they also meet on an as-needed basis. They use text messages, email, and phone. Possibly they're looking at, to help streamline, and I know I hear this part a lot, that the geographical spread out in rural communities makes it hard for in-person meetings, but video conferencing has become more affordable with different models out there as well to help have those team meetings. I'm going to take the time now to transition to Deb to talk more about how to engage and to address community partners.
Thank you, Alyssa. If Kim had put up the poll question now, I just want to find out how many of you have someone that does some sort of discharge planning, and by that I mean connecting your patients with community services. And if you do, what's their background? And that's something that I'm very interested in finding out. Are they a nurse practitioner? a RN, a social worker, you know, what kind of background do they have? That's very helpful to us to understand that. Thank you for that.
Great to see there are RN and social workers.
Mm-hmm. All righty. If you don't have a formal care coordination program right now, in a sense that discharge planner, if that's what I may call this person, is doing care coordination. They're connecting the person to resources in the community. And in some cases, reality is that they are a one-person care team. Now, Alyssa just has finished talking about the importance and the effectiveness of having a true care team, a very interdisciplinary group of people. And I'd like to revisit one of the slides from yesterday, in that healthcare can't change health outcomes all alone. The challenge here is that we have to look at new ways of working with community partners, and for everybody to join in and take responsibility for their community's health outcomes, which is a long way of saying we really have to engage the community and community partners. But I'd like to offer to you is that that discharge planner may be the connector into your community, because they are already connecting people with the community. As hospitals, state stakeholders, and networks, you need to know your community. And to get you thinking, what are the not-for-profit organizations in your community? Do you have a living at home block nurse program? What about the volunteer organizations that are coordinating activities that allow a person to recover or to stay in their home longer? And then there's a number of communities that have health coalitions that have come together. What about the other healthcare providers? What about the clinics in your area? There may be another hospital. What about the private practices, long-term care, assisted living providers, hospice, rehab? Don't forget about your local and county government agencies, public health, adult and child protection, human services, aging and disability services, and veterans. As Alyssa mentioned, schools are playing a stronger role all the time, and so include those. Include the school districts, the community colleges, the universities, both public and private. Who are the advocates and aid organizations in your community? The Ombudsman. Do you have Catholic Charities? Lutheran Social Services? What about the community action programs or the economic opportunity agencies? Making sure to include a good scan of your faith-based organizations, because many churches have specific programs to meet their parishioners' needs and to reach out to the community. And many communities, and hopefully many of your communities, have parish nurses that can play a huge role in care coordination. Who are the housing providers? The independent living, cooperatives, and high-rises. And I often laugh at that. The community that I grew up in, the high-rise was 3 floors high. The community that I live in rural Minnesota right now, has a high-rise that's 6 floors high. What about the local businesses and business networks? Who's the medical supply business? Home health care, the fitness center, transportation services. If you already haven't generated a list of all the different types of community organizations, and this is just to get you thinking, remember, this is one of the first steps that you need to do in community engagement. Engage these people that you've identified in your community in conversation. A conversation focused on a common vision around the target population and care coordination. Build collaboration between these community organizations and entities. And you may also find organizations that you may want to develop formal partnerships with. through a memorandum of understanding or memorandum of agreement. Poll time again. Ask this question: our organization collaborates with public and private organizations in the community to assess and improve the health of our community. Do you strongly agree, somewhat agree, somewhat disagree, strongly disagree? Well, it's becoming very apparent that a number of you do collaborate with public and private organizations in your community already. But so you really already have that experience that there's a lot of aspects of community engagement. And I would really like to encourage you to take some time and look at the patients, partner, and community section of your rural hospital toolkit for transitioning to value-based systems. There's a lot of samples and types of community engagement there, but I'd really quickly like to just do this high-level look at things that you might want to be thinking about as hospitals, state stakeholders, and networks when engaging the community. Because community engagement alone is a 1 or 2 webinar series, so that's why I just want to do this really broad brush if we can. The first thing, though, that I really feel I need to say and want you to know is that these community partners want to engage with you. I've been working with community-based organizations for years, and in the last, say, 5 to 6 years working toward that care coordination effort. And when I'm meeting with community organizations, they're saying, if only we could involve the hospital, or having the hospital and the clinics involved is so important in our care coordination. And just to be honest with you, many of them just don't know how to do that. So with that, I'd just like to remind you or just really encourage you to go where those community resources are. Be the one that extends your hand first. Invite them to come together and talk about the common vision. Be accessible. Open your doors to them. And by that I mean, can you designate a point person, a common entry point, if you will, someone in your organization that the word can get out in the community that it's Marcia or it's Robert that we call. And that's how we get into working the person that channels us into the correct place within your organization. So think about that. Another thing is to take into account some possible cultural differences and circumstances. And when I'm talking cultural, I'm talking mainly work culture because it may be different than your organization. And also, your organization has multiple employees, and these organizations in the community that you're working with may have only 1 or 2 staff people in them and work with a lot of volunteers. So just keep in mind that community organizations may not do business the same way as yours does, and that's okay because they are getting some good work done in the community, but just to understand that. And invest in ongoing relationships. When you engage the community, it needs to be for the long term, not just for one project like a care coordination project, because that way you can lose trust. So, you know, you're in it for the long haul, and that upfront time will definitely pay off down the road. And fostering community capacity. Without a doubt, there are community organizations that can augment your efforts by building their capacity that will just bring you further down the path to value-based models. You have partners in the community engaging in that patient as well. So there's other people who are coming around that patient or that community member to build a healthier environment for them and encourage them to be healthier. As a successful care coordination program moves forward, community engagement is a must. And for more information on that, I remind you to turn to your toolkit, but also feel free to contact us here at the center, because we are here to be a resource for you. Another way that we can be a resource is through technology information. Joe?
Thanks, Deb. I'm going to talk a little bit about technology and hopefully not bore you to death. Some of the key things I'd like to get across about technology is use what you have and be comfortable with an incremental approach. When Alyssa went through some of the discussions on care coordination and showed the care coordination worksheet, you saw under the technology, how are they using technology to support care teams and care plans. You saw that they were using Excel, they were using text messaging, simple things that they already have. Don't fall for the trap of we have to have a specific care coordination system, or we have to purchase a module from our vendor. That can help, and you want to be able to keep that on the horizon strategically, but you don't have to use that as a barrier. It can be something that you want to support. Once again, information technology should be supporting your processes, and sometimes to effectively do that, you have to work through the processes for a while before you get the technology. So having a system is really only the beginning. If you have an electronic health record, you probably know today that if you go and do a report out of the system, that sometimes you run into data integrity issues. I always like to talk about the example of smoking cessation advice in the emergency room. Many organizations, when they run that report to see how often they communicate to their patients that they should quit, and sometimes those numbers come out at 10%. When they start looking a little deeper, they find out that there might be 4 different places that people can put in that data that they did talk to the patient. So data integrity and standardization are really critical, especially when it comes to care coordination. We're starting to see an emerging market of cloud-based systems that are just for care coordination. These are interesting systems because they're written completely from scratch. They're all designed with modern development tools as opposed to your EHR, which is probably developed with tools that were invented in the 70s. These are new systems. They're going to be pretty disruptive, I think. One of the issues that we see about these systems is that you typically do have an additional login. So, you know, a care coordinator or a nurse or a physician even will have to keep in mind another place to log in, another login and password. That's a frustration, right? It's another location for data that you need to be aware of. So when you do a HIPAA privacy and security risk assessment, that is a data location you have to do a risk assessment for. It's cloud-based, and there are things you have to do, but you have to be aware of that. Ease of access. These systems are typically very easy to use, and you know, when compared to an EHR, they don't capture as much information. It can be a lot simpler than your electronic health record. But most of them have a limited ability to be able to transmit information to another spot, like an electronic health record or a health information exchange. Currently, most of them are pretty dead end. But data collection is going to be something that's really, you know, it's core to care management. And how do you collect that data today, and where do you see that data going in the future is all important things to consider. Communication systems, another function of information technology is the ability to communicate, right? And I think we mentioned before that that communication systems can be everything from a post-it note on the computer monitor to health information exchange. And there are a lot of ways to communicate. Don't assume that you will just use one. Oftentimes people will say we're waiting for the state-based health information exchange, and we're waiting for the funding to be able to hook up to it effectively. You don't have to wait. There are already ways that you can communicate effectively. And the second one on the list, direct secure messaging, is one that I encourage you to implement. Direct secure messaging is nice because just about anybody can sign up for it. I, as a patient, have a direct secure address, for example. So direct secure messaging is a nice way to be able to communicate with providers who maybe do not have an electronic health record. Folks like hospice, home care, long-term care, they can all participate in direct. You're using telephone today. Your electronic health record can usually message internally. But, you know, I'd just like to reiterate, don't assume that you need just one. You will be using, you'll be using many communication technologies, you know, even fax. We can't get off of fax today. We mentioned earlier that the members of the care team really are going to span areas of healthcare that maybe you haven't considered in the past. And in addition, it's probably going to touch folks who are not considered part of healthcare. They're really ancillary to it, like schools. So if you're working with a school nurse, you have to fall under the FERPA regulations, as well as HIPAA. FERPA has some very strict regulations on what information can be shared about a student, and that does apply to school nursing and anybody who is operating within a school. So it's important to understand what other privacy and security concerns and regulations you may have to be aware of. I list 42 CFR Part 2. If you're working with behavioral health organizations, that is an important regulation to understand. And it puts an extra layer of privacy and security on top of electronic health records, particularly those that have to do with substance abuse. And if you need to share information about substance abuse with another provider, that has to be a dead end. You can't redisclose that information, or that person you released it to cannot redisclose it ever again without consent from the patient. So, and then finally, probably the most important thing are state regulations. I'm going to give you an example from Minnesota on how our state regulations are much more strict than HIPAA, and yours probably are too. I'd like to close out my my session to talk a little bit about some myths that I hear. And the myth, HIPAA is not a patient issue. It should say up there. I hear people think about HIPAA as something that really affects hospitals and clinics, but it really is a patient issue. Patients expect their data to be secure. When you think about where you have data with your bank, with your car oil change even, that data, you expect it to be secure. You don't want people to be grabbing your information and stealing your identity. So they expect it to be secure, but on the other hand, they also expect that we as healthcare providers are able to communicate that information freely with those who need it in healthcare. You know, they really get frustrated when they have to give personal information to multiple places, even within the same organization. So patients really expect that data to be shared, and further, they do have the right to their health information. If you're storing it electronically, it is their right to say, I want a copy of it electronically. Most patients don't know that, and those that do can be very persistent on it. They have a right to their health information, and it does not have to be through a portal. it can be exported out. That is their right. So keep that in mind, and also keep in mind who they're comparing you to. We hear this all the time. How come I can go to an ATM in 5 states away and it instantaneously takes money out of my account, but if I go to the clinic that's attached to my hospital, they don't know anything about me? So they're going to compare you to that. I put Delta Airlines on there. I'm always amazed that when I fly, because I travel quite a bit, and most of the time it's through Delta, all the things they know about me. When we book the ticket, they always have me in the seats that I prefer. They manage all of my information really well, and if I need to transfer to another airline, all that information seamlessly goes over if I get bumped or something like that. So, that's who they're comparing you to. One myth, and this is the example in Minnesota, that HIPAA really does not require consent in many, many instances of disclosure. They don't require consent. But, for example, in Minnesota, they require consent for just about everything. So your state laws are something you really need to be aware of when it comes to sharing, especially when you're considering care coordination and sharing with providers that maybe do not know about HIPAA, have never heard about HIPAA. That's a pretty steep hill to climb. Finally, these are some myths that I think generally I hear all the time. And one of them is that if we just put in a single EHR, it'll solve all of our problems. There are a lot of electronic health records that really do a nice job of having a clinic and a hospital system. Maybe they have long-term care as well, but they probably don't have something for your entire referral network. And much less than that, they probably don't have anything for school nursing or corrections. You're not going to get your local corrections, if they're one of your partners, you're not going to get them to switch to your EHR probably. So we have to be comfortable with interoperability, and this is a big issue in healthcare IT right now, but it's something we have to get comfortable doing, and there are ways to do it today that we're not. I mentioned direct secure messaging. I often hear from folks that they really see that as a short-term strategy. They're not going to look at it. I think that's baloney, because we're going to use direct and other things like telephones even when we have full query-based health information exchange. I encourage an incremental approach. By doing incremental approaches, you can really make fundamental change over time. And direct is one of those that we can all do today. It's very, very low cost. It's very simple. It looks a lot like email. It is email, as a matter of fact. And there's no reason we aren't using it today other than a bunch of misunderstandings. And then finally, I hope we are over this, but I hear this all the time from people, that our patients are too old to access their electronic patient data. And to that I say balderdash. That studies have shown otherwise. When you talk to the Veterans Administration, for example, they talk about their average age of the patient that accesses the portal regularly in Minnesota is over 65. I think the average in Minnesota is like 72 or something like that. They're doing it. They're able to do it. That's not an excuse anymore. And even if it is, even if you do have a rural population that maybe doesn't have good internet access, they at least have a caregiver who will want to access that portal. So be aware of that. I always like to say, you look at how many of us have older relatives who have a Facebook account. EHR vendors are looking at that, and they're saying, if folks can use Facebook, why can't they use a portal? So they're trying to design their systems to look a lot more like Facebook and a lot less like a sterile medical patient portal. So keep that in mind. And with that, I'd like to turn it back over to Alyssa and Deb.
Great, thank you, Joe. And in summary, we're coming to near the end of our time today. And in summary, here are the components or the areas that we spoke about over the last 2 days. We talked about the role that care coordination will have in achieving the goals of the triple aim of improving quality, improving outcomes, and decreasing the cost of care. We talked about 4 fundamental components of a care coordination model, along with health information technology considerations and privacy security issues, and then how to outreach and engage your community partners. I'd like to thank you for joining us today, and Kim, I'll turn that over to you to see if we have any questions or any comments from our audience.
Thanks, Alyssa. Thanks, Deb and Joe. If anyone has any questions, feel free to type them into the chat box. You can hover over my name in the attendee list and send me a private chat, or you can press *2 to unmute your line. Joe, when considering purchasing a care coordination system, what features should people look for?
Good question, Kim. Care coordination systems, especially cloud-based ones, are really kind of an emerging technology, like I mentioned, and we're seeing a lot of them really evolving rapidly. I often, when I talk to those vendors, I try to see how they are sharing or capable to share with electronic health record vendors or health information exchanges, and many of them are not right now. I think that's an important feature, to be able to, receive lab results and receive reports directly from an electronic health record, and particularly to be able to send the care plan back to an electronic health record, I think is an important feature. Your care coordination project is going to be unique, and I think a level of flexibility within the system, the ability to change templates and modify them for your unique workflows and your unique members of your care team. That's a really critical feature to have. You don't want something that you have to build from the ground up, but you want something that is at least very customizable.
Thanks, Joe. Anyone else have any questions for Joe, Alyssa, or Deb? Here's a question. You say long-term engagement. How long and how many meetings are we committing to when we start engaging the community?
There's, when you're setting up a care coordination program, you're setting it up for the long haul. But my experience when first pulling community partners together to come up with that vision, when you're asking people to start to commit to a meeting, we're probably looking at 2 to 3 meetings. One, to say this is kind of what our vision is, and get them to come around a vision, which may be slightly different than what your organization's vision is, but it's a community, a consensus vision, so you can move forward with that. And then coming together again to decide how to move forward. And out of that, after about a 3rd meeting, I think you're going to have a group of people that may be very interested in really coming around the care coordination, being consistent members of care teams. But you might also have a group that's coming together saying, these are some gaps in services that we are going to develop for our community. So there might be small work groups coming out of it, and someone from your organization, or as that whole team in the community is coming together, would need to keep those things moving forward. And so it's a constant thing of looking for gaps and finding those community organizations to take and come around it. So, I mean, we're looking at an investment far into the future in order to take and have a healthy community, but that is all what population health is about.
Thanks, Deb. What's the best way to identify members to be on the care team?
That's another good question, and this is Alyssa. And going back to thinking about the population, the target population that you're working with, and the assessment tools that you're utilizing, whether it be looking at their social functional needs, behavioral needs, and or clinical needs. So that's a good indicator of the provider team, the interdisciplinary care team, from a provider, social services, public health, behavioral health standpoint. Also, asking the person, asking the caregiver, who, you know, this is who we really recommend, who is important to be on that, but we understand that there are people that are important to you, whether it is your loved one, whether it is someone from a volunteer organization that is important and supports them and that they trust and is that link between the clinic and or hospital and themselves. So there's some good tools and resources that will identify that you'll be using in your model, but it also will be to be asking that person and or their caregiver.
Great. Thank you so much, Deb, Alyssa, and Joe, for a great webinar series. The recording of this webinar, along with the slides, will be available on our Help Webinar Playbacks page later today. At this time, I ask that you complete the short online assessment for this webinar. Use the links on the screen to register for any of our upcoming webinars or PMG calls, or to download educational guides or the Rural Hospital Toolkit for transition